Tokayer, Rabbi Zusha, ich will mir eure sagen, als die Menschen, was halten sich mit dem Mann von der Schkie, hat der Schkie in der Erde auf Esser Fleisch gedämmert, hat der Schkie ist Mamisch für eine Minute 8:24. Makdim, Chitz von dem, was man eure auf verschiedenen Unionen, geht man ein Step weiter, mit Titze der Sache, gleich noch dem Sibbe, Elzan, ausgereihe du in der Stieb, 4 General Health Practitioners, wir sind mich in dem Simmen, zu empfern, in Ost zu helfen, auch zu schreiben, Menschen sollen sich anschreiben, sollen sich kommen geben, ein Visit. Was ist gut, eine wichtige Sache, nehmen noch ein Step, nicht nur reden davon, tun sie die Sache as soon as possible. As for the high point of this evening, I'd like to introduce Dr. Shimshi Zimmerman, who will moderate tonight's health panel. Dr. Zimmerman is the medical director of Atzula, and so in some level, each and every one of us owes him a certain level of gratitude. Let me introduce you to 3 doctors with him, each one of them giants in their respective fields. Dr. Aaron Tokayer, who's, by the way, my doctor as well. Dr. Inzlicht-Sprei, and Dr. David Sherman. Gentlemen, thank you.
Good evening, everyone. Thank you for the introduction. Careful. I have to personally thank Chasky Rosenberg and Chaim Fleischer. I assume for putting together this wonderful event and for asking me to moderate and speak. As said before, I'm Shimshi Zimmerman. I'm the medical director of Chevra Hatzalah of New York and the medical director for Centers Healthcare, Boro Park Center. I have the honor tonight to be joined, as the emcee said, about 3 individuals, physicians, giants in their own right. I'm going to reintroduce them. Dr. Eli Inzlicht, general practitioner of primary care, here for Premium Health. Dr. Aaron Tokayer, gastroenterology, Makdim extraordinaire, and Dr. David Sherman, cardiology from Columbia Presbyterian. I also have to thank all the other medical and healthcare professionals that have joined us here tonight that help take care of all of us in the room, all of our patients, all of our mutual family members. Tonight's goal is already a huge success. And I say that because when I walked into this room about an hour and a half ago, I saw what appears to be 50 empty tables. And I said, there's no way that this room is going to look full enough for anybody to say that, enough people attended. Baruch Hashem, look around the room. You've all taken the first step into improving our health, into improving our life, and improving for our families. The goal was to get people in the door to hear tonight's speakers. There's a lot to talk about. And we've had wonderful speeches and introductions by the Rabbanim, I think from what I understood from my limited Yiddish, about the importance of taking care of our health, about seeing your healthcare provider, about referring yourself and your patients to the specialists that are needed. We've composed a list of questions, and we've taken some insight from people who had some questions, just how to go about that. What's important? What do we really need to do? And so I think we're going to start off with some general questions, and I'm going to ask my respected colleagues here to sort of give their input, to share their experience and their expertise. So the first question that we really asked, and I'm going to direct this to Dr. Inzlicht, is what is a primary care physician, and why do I need to see one?
Well, hello, and thank you very much for coming and for having us here. Primary care physician is exactly the way it sounds. It's a doctor that gets to know you. It's a doctor who you go to on a regular basis, who will do the basic testing, basic visualization, basic whatever has to be done, and you build a relationship. That's the doctor usually if there's an issue, a problem, or if there isn't an issue. You come in, and he does the tests that are either preventive or if there is an issue, and he will either refer it to someone if it's beyond his training, and sometimes even if it is within his training, he may want to have a specialty involved. I mean, Baruch Hashem, today's day and age, especially in New York, we have available a slew of basically all types of specialties, or he will guide you in the proper direction. So it's very important to have a PCP, a primary care, and historically, medicine has always gone in that direction.
At what age would you say someone needs a PCP? Is there a specific age?
Well, the problem, and some of our speakers before were talking about the prominent about diabetes and many of these conditions start at a very young age. And, a lot of people say, well, okay, used to be 50 for colonoscopy, now we bought it for 45. We recommend screening at a very young age, and from 18 on. That doesn't mean a yearly screening, but screening basically, there's family history, there are genetics involved, and sometimes non-genetics, because a lot of us don't know our genetics. I mean, we know, I know my parents, I didn't know my grandparents, and even the ones who knew the grandparents in Europe, who heard of a colonoscopy in Europe? Who knows what a pancreatic tumor was in Europe? Somebody didn't feel well, and Zanavek, that's it. So we recommend to start basically after you complete your treatments or you're following with pediatrics and go to a PCP. Like I said, that doesn't mean on a yearly basis initially, but they will guide you depending on what they find. And in many cases, as I say, we already start seeing problems at an early age, weight-related issues, early diabetic or pre-diabetic as we call it, which we could talk about afterwards.
Okay. I'm going to ask Dr. Sherman, can you explain a little bit of the differences between what a primary care physician can do and what might require a cardiologist to do on health screening, especially when it comes to hypertension? And let's even discuss what is hypertension.
Just before I get to that, I'd like to thank everyone for giving me the opportunity to come here. I basically became a doctor and chose my particular field like a lot of doctors do because of personal experiences that they had with their own families. My father became a Yassam at age 17 because his father was a smoker, and I don't know what his father's cholesterol was or what his father's blood pressure was, but I knew that his father was a smoker and died suddenly in his 60s of a heart attack. My mother's brother, who was a Rebbe in the yeshiva in Brooklyn, was in his 50s, came home from shul one day, never had any kind of history whatsoever, and just keeled over in front of his family and died. And they had to spend the whole Shabbos watching this person, and he obviously had a heart condition and had a heart attack. And both of those situations, the whole concept of being able to prevent things like this from happening is very powerful for me. The whole, this dying suddenly, sudden death, still occurs today. 300,000 people every year die suddenly or have a cardiac arrest in America. Only 10% of those people survive. So it's still going on to this day, even though we know so much more about cardiovascular disease. Cardiovascular disease still kills around 750,000 people every single year in America and is the leading cause of death in America. So it's really important. An event like this is so important because it brings knowledge to people about the things that they could do to try to prevent things from happening. And the truth is that many of these things are preventable because cardiac disease doesn't just come on out of the clear blue. There's always something that contributes to it. As far as the most common cause of cardiovascular disease, which are diseases of the arteries that lead to heart attacks, people have to have an underlying condition in order to develop that, such as high blood pressure, or diabetes, or high cholesterol, or people who smoke, people who have sleep apnea. If a person does not have any of those things, and if no one in their family has ever had a heart attack, they're not going to have a heart attack, most likely. There has to be a cause. You have to have those things in order to develop a problem. And all those things could be diagnosed at a relatively early age if people go to a good primary care doctor who could alert them of those things. So I think that the most important thing for someone's health is to be able to find a good primary care doctor that alerts them to some risks they may have of developing some kind of heart disease in the future. Now, as far as the question you asked me about hypertension, as far as I'm concerned, most good general internists know how to treat hypertension. Hypertension is that there's dozens of medications for it, and I think in general, most people do an excellent job of treating hypertension. Usually, the type of cases that I get asked to see are ones that are a little more difficult, where that people are on 3 or 4 or 5 medications and things are still not working. So as far as things like hypertension, as far as things as diabetes, as far as things as high cholesterol, the most important doctor a person could see is a primary care doctor who will get them on the right track in order to focus on all those things as preventative. The one area where I think a cardiologist might have some more insight is the concept of family history of a heart attack at a young age. And that is, according to the general consensus, if a male in your family, either your father or a brother, had a heart attack under the age of 55, or if your mother or sister had a heart attack under the age of 65, that is abnormal. And that may reflect, for the person, whatever happened, but I'm talking about the other people in the family should be much more attuned to their risk of having that and do some special tests which may not be routinely done in order to see what their particular risks are. I mean, I have people that come to me at a young age because someone in their family had a heart attack, their father had a heart attack, and then after doing all the testing, I tell them, I think you take after your mother because you're fine, there's nothing wrong with you. So it's important, I think, for people that have that kind of family history at a young age to be very, very conscious for themselves about what their risks are, even if they don't think they have any.
Dr. Inzlicht, can we go through what we call hypertension? What are the numbers, or what are we looking for? Because we get a lot of questions. Why can't I just take my blood pressure at home? Why can't a Hatzalah guy come and check me out? And if I have high blood pressure, won't it just go away on its own?
So that's a very good question, because the usual misnomer is that I have high blood pressure. Well, I'm nervous today. The stock market went down 5 points. My children were screaming in the car. Studies have shown that, yes, something can elevate a pressure on a short-term basis. But you see a trend, and people know this. People will tell you, I've never had blood pressure. Yeah, but last time I went to the urgent care because I had a sore throat, they told me my pressure was 160 over 100. But I figured it's because I had a sore throat. No, that's not because you had a sore throat. There is a problem of hypertension. Unfortunately, we don't understand totally hypertension. I know in this day and age when we have all this, we don't understand totally the mechanisms, but we do know that we can treat it and we can prevent the consequences of hypertension. As we just mentioned earlier, genetics is a major factor. We see hypertension running in family, and it's not a patient's nature. You'll see a family where either a father, mother, or both, or a sibling, brother, sister has hypertension. Now the question is, so I'll check it myself. It's actually a very good idea every so often to check it, because if people come to, like we're talking about preventive medicine, once a year, and either it's excessively high because, again, I was waiting in your waiting room for 45 minutes, I'm nervous. So it is a good idea to check it on a regular basis, because that's probably one of the most preventive conditions that we could do something about, and more so than almost everything else, which we will discuss some of them. It's easier to treat, and we could really prevent a lot of consequences from hypertension. Now the question you mentioned is numbers. The numbers, like when I started medicine a long time ago, and at that time they said, anything 160 or above is hypertension. Anything below 160, don't worry about it. Diastolic, 105. What happened? They've learned. They've done studies. The medical profession, the scientists have done studies. And those numbers have come down, and they've done gradually. But really, anyone who's over 130 on a regular basis has to, now, I'm not saying right away has to start, lifestyle change, of course, and it's not difficult lifestyle changes. Everyone thinks lifestyle changes, I have to lose weight, I can't eat this, I can't eat meat, I can't. No, yeah, there are changes you can make which are better for your overall health. It's not just the hypertension. And many people will have a diastolic issue, which again can impact the heart. So it used to be always 120 over 80. Nobody's 120 over 80, 135. 135 is high. And if you see consistently more than 2 or 3 times, that needs treatment. So it's something that, like I said, if we get anything tonight from this whole meeting is that let's treat the high blood pressure, you will see a major improvement.
You might often hear high blood pressure, hypertension be called a silent killer. It's because your body doesn't tell you that your blood pressure is very high. Your body's not going to tell you that your blood pressure is 150 over 90. And yet you might sit there for 5-6 years. 150 over 90 won't kill you today. But 5-10 years of untreated, uncontrolled blood pressure in the 135, 140, 160, or even 180 range will definitely lead to a lot of the issues that you would end up being referred to some of the specialists for. Dr. Tokayer, I do promise I will get to you, but on the topic of cardiovascular disease, I just want to ask Dr. Sherman, when should I be referred for a stress test? Not that I want one, but,
With stress tests, I think are not just a test that should be ordered routinely. I would say a stress test should clearly be done in any person that has any symptoms that are concerning for heart problems, such as chest pain or shortness of breath or other symptoms that one is concerned about. If someone is 35 years old and healthy and doesn't have any heart issues, they don't need a stress test. So a stress test should be geared towards people that have heart symptoms, or this group of people who have a family history of heart problems that may not be aware of it themselves, but you may want to bring it out. So I would say a young person who's healthy with no cardiac issues doesn't need a stress test. On the other hand, people who have high blood pressure, anyone with high blood pressure should probably have a test called an ultrasound, which is an echocardiogram, because high blood pressure can have effects on several different organs. One of those organs is the heart. So anyone with high blood pressure should probably at some point in their life have an ultrasound just to make sure that the heart is not being affected by the blood pressure.
On that note, you mentioned the number 35. If I'm 35 and I have chest pain, I can't be having a heart attack, right? Why do I need to go see a doctor? Why do I need to call Hatzalah?
That is not true. 35-year-old people can have cardiac problems, can have chest pain, and it could be heart-related. First of all, unfortunately, I've seen people in their 30s have heart attacks. So as far as I'm concerned, a symptom of chest pain should not be ignored by anyone, no matter who they are. Women there's a certain group of women who are susceptible to a condition where one of the arteries has a tear in it in the heart. They're very rare, but they do happen. So no matter how young a person is, if people come to me with chest pain, I never tell them that they're crazy. It has to be evaluated. It's a little unusual for someone who doesn't have a family history, who doesn't have some of these other things, to have a heart attack at age 35. But there are other things that could cause chest pain in people 35. We saw a lot of that during COVID. And it's not just during COVID, but throughout my career, viruses can affect the heart and cause inflammation of the heart. And that could present as chest pain. And that's a serious condition. And therefore, the answer to your question is anyone with chest pain, no matter how old they are, should go to either a primary care doctor or a cardiologist to get that evaluated. Most of those things may end up being nothing, but at least you want to make sure that there isn't a problem underlying it.
And so I'll just add in, there's a lot of potential causes and potentially serious causes for chest pain in 30-year-olds or 35-year-olds. So as Dr. Sherman said, the 35-year-old who's overweight, who's a smoker, whose father had a heart attack when he was young, who has prediabetes, who smokes, I think it's a little bit of a higher risk that potentially something serious is going on with chest pain that could be a sign of cardiac damage. But if you're having any type of chest pain or a concerning symptom, I agree. If you feel that you're okay to go to your cardiologist or to your primary care doctor, great. If there's anything more serious, here's the plug. You can call Hatzalah. We'll gladly take an evaluation and refer you hopefully to an appropriate emergency department where you might get evaluated with a stress test if indicated. Great. Okay, Dr. Tokayer. Makdim has done a tremendous amount of work and fortunately has found the unfortunate, very significant disease earlier on in a lot of patients. So at what age does preventative screening, mainly from a gastrointestinal perspective or colonoscopy, really start? And what should that screening look like?
Let me start by thanking you for having me here tonight. It's an honor to be here with you. I have to say, kol hakavod, or I guess I should say, shkayach, to Makdim, the Makdim program, but also to all of you for being here, to have an initiative, and to have an interest in participating and taking care of yourselves. The question came up about colonoscopy, and it's true. The Makdim program has done tremendous work in terms of organizing the community. Prior to, I believe, a year ago, I think our community, unfortunately, was very, very far behind national standards in terms of preventive procedures of colonoscopy or colon prevention, whatever procedure that would have been. The national standards are that a community should have at least 82% of eligible people being screened, and in New York, the numbers of percentages increased over the past decade from about 40 to about 62% and on the way up towards 82%. I think our community, I would venture to say, probably had less than 20%. But over the past year alone, I would say really half a year, Makdim's been doing this mostly for the past half year, for the most part. I know that 1,000 people have been referred for screening to various areas, to various hospitals. I know personally, I'm told that I've taken care of several hundred, and out of those, 60% of people have polyps. More than half, 60%. Most polyps probably would not become a problem, but almost all cancers came from polyps that had too many years to grow. Because of that, preventive colonoscopy to remove polyps is recommended in people age 45 and up. It used to be 50, but now it's 45 because there is an increased incidence of colon problems in young people, unfortunately. Still, colonoscopy age 45, and I've been seeing mostly through the Makdim program, people age 45 to 50, not even the older people, 45 to 50, people have been coming out of the woodwork. And 60% of people have had polyps, some of which are very advanced, some of which are already cancerous that could be removed and have been removed with simple colonoscopy, a 20, 25-minute test. And if something is found early that can't be removed, it still can be treated much better when found before it finds you. So we have to find it. Age 45 is the age for screening colonoscopies to prevent problems in the future. And of course, family history plays a role like it does in other areas of medicine. So if there's ever an issue or a question, you have to talk to the primary care physicians, you talk to the other physicians. Doctor means educator. We are all educators. We're here to help educate and to take care of people together with them so that we can take care of our community in the best way possible and prevent problems. People should have arichos yamim with good function and good health. And it's also a wonderful precedent for the family to take care of themselves when they see people in our generations taking care of ourselves appropriately.
And I can say that I'm a little bit younger than 45. I had my routine screening colonoscopy. I was actually found with an advanced polyp that thankfully was removed. What Dr. Tokayer was sort of saying is that preventative colonoscopies are great for this screening. However, they can also identify and completely treat and cure polyps, which can be precancerous lesions, or even identify an early cancerous lesion that can hopefully go on and get definitive curative treatment. Can we just ask Dr. Inzlicht for a quick question? When does prostate screening begin in men as well?
Well, prostate screening at this point basically is mostly a blood test, a PSA. There are newer, more specific tests that have been devised, but they really haven't been approved yet, and it's not used commonly. So the screening I'm talking about before we go any further, the recommendation is from 50 years on. If there's any family history, then we do it earlier, and as earlier as necessary. It's a blood test, and it's only a blood test, so it's not, there's nothing invasive. Years, not so long ago, they used to do a rectal exam. It was very uncomfortable to feel the prostate. Basically, the National Cancer Society said, it need not be done, not with the advent of PSAs. The problem is that by the time you find something on a rectal, by the time you feel a mass, it's already grown and it's too big. You should have detected it earlier. So 50 is the time when we do the initial PSA. But again, it comes with a history. That comes in with a PCP. You get it. And if there's been in the family, we do go earlier. We'll go in the early 40s. And I've actually seen it in late 30s already. So I do screen after 40, even though, just have to recommend.
With a simple blood test, the PSA?
Simple blood test.
Okay. Dr. Sherman, what is high cholesterol? How do we test for it? And how is it primarily managed? And I know for the most part, most of the patients will be managed by the PCPs, but figured we'll turn it back to the cardiologist.
Well, cholesterol is a molecule that can potentially build up plaque if there's too much of it in the heart. in different arteries of the body. A blood test for cholesterol, there's a blood test for cholesterol that's pretty simple. It measures the total cholesterol and then different components of the cholesterol, one of which is called LDL, which is the bad cholesterol. One of them is HDL, which is the good cholesterol. And the other one is the triglyceride level, which is separate from cholesterol, but it also is a fat that could build up, and levels of which you want to keep normal as well. Because triglyceride levels could fluctuate very quickly depending on foods you eat, it's better to take the blood test for cholesterol when you're fasting, because the LDL, which is the bad cholesterol, is really not measured directly, but rather derived from an equation involving the HDL and the triglycerides. So it's always best to measure cholesterol when you're fasting, like an overnight fast. As far as what is a high cholesterol, there are different gradations of cholesterol depending on a lot of other risk factors that a person has. In general, we focus on the LDL component. And if someone has an LDL of greater than 190, that's sort of, every doctor would agree that needs to be treated. On the other hand, if I see someone for the first time, I don't initiate treatment on them if they have a high cholesterol, if they feel there are things they could do in their diet or lifestyle to modify the cholesterol. There's no doubt that certain foods that are very high could raise cholesterol, such as cheese and eggs, and people could lower their cholesterol by 70 to 100 points just by modifying their diet and their lifestyle, by exercising more, by losing weight. The process of building up of plaque to cause a blockage and heart attacks is a slow one. So you don't have to rush into, my philosophy is not to rush into anything the first time you see someone. Just give them an opportunity to try to get things lowered on their own. But unfortunately, some people have a familial tendency to high cholesterol. They could be thin and eat the best foods, but there are certain genetic predispositions, and they'll say, yeah, my father has a high cholesterol, my brother has a high cholesterol. So in those group of people, no matter what they do, they're not going to lower your cholesterol. So I would say offhand, a total LDL of over 190 for sure requires treatment. A lot of these other values come into play depending on what a person's other risk factors are. For example, a diabetic who has a completely normal cholesterol, the recommendation of the American College of Cardiology, American Heart Association is every person who is a diabetic has the potential of developing heart disease because of what diabetes could do to the blood vessels. So even if they don't have a high cholesterol, the recommendation is to treat people who have diabetes as if they have a high cholesterol. Now that doesn't mean you may not need the same doses that other people would need if their cholesterol is 300. But treatment is recommended because diabetes is a condition that very likely at some point in a person's life may lead to vascular problems. Now, as far as treatment, the standard treatment that we use are a group of medications called statins. I'm sure everyone has heard of them. I'm sure everyone hates them. I spend half my day negotiating with people that these are medications that they're not gonna kill you. The truth is that they do have there are side effects in people with these medications. Thankfully, most people don't have them. Some people do have them. Most of them are muscle aches and muscle-related symptoms. And if that does happen, there are other options nowadays to deal with that other than. So I have plenty of people who can't tolerate them as medications, and we choose something else. But I think it's important to accept the fact that if you have the kind of numbers that are so high and there's nothing you could do with your diet or any other thing in order to lower it, you should try to take a medication in order to lower it.
I think that's a perfect pathway to continue into the next conversation. We'll try to go through it a little quickly. Dr. Inzlicht, why is diabetes dangerous?
Well, first of all, I know we're trying to save time, but let me just say, let me say that diabetes everybody thinks is my sugar. Diabetes is sugar. Diabetes is not a condition of sugar. It's really, that's what we can measure. That's what we were able to measure. But like Dr. Sherman was just saying, diabetes goes on multiple complications. It's really a vascular condition. And when goes untreated or uncontrolled, ultimately it will cause vascular problems. And, we've all heard of diabetic ulcers, diabetic retinopathy. It all comes because there's no flow to the organ that should be getting more blood. So you can have a kidney problem, a heart problem. Basically, any significant organ could be affected by diabetes. So why is it sugar? Well, we're not going to get into pathophysiology about the insulin, but really what happens is if we can control the sugar, because that's what we can measure, we could stop the progress, or at least slow down the progress, depending how well we control it. If we don't, like the first speaker that we had today, when he had a stroke and they came in and they said his A1C is 13, there's no reason this day and age that anyone should have this happen. There's no reason. It's easily available. You can go to any doctor. Today they have tests that you can buy at the pharmacy. You can be checked, and you can stop these conditions. So diabetes is not, like I said, it's not a question of sugar. I'll just cut out. I won't have my kokosh cake, and I won't have the chocolate cake. I'll just eat. I'll put some Splenda. That's not enough. You really have to determine what it is, and if not, it will lead to complications. It could take years, but it will. And the other thing I just want to say, we're mentioning hypertension, that it could be silent. Diabetes in the early stage, in quite a while, can be silent. Again, like the first speaker, when he said he had A1C of 13, he didn't even feel it. Not everyone has symptoms. Many people will have more symptoms, increased urination, thirst, but more or less, when there are symptoms, it's already past that early stage. So if we could do something early on, stop it or detect it and treat it, I think we could benefit a lot from it.
So we've now heard diabetes is not just a sugar problem, but right, that's what alerts us to the fact that maybe someone has prediabetes or diabetes, a random high sugar, or a simple blood test, even sometimes the finger test now for an A1C that's elevated, but basically causes blood vessel problems, vascular problems. Our blood vessels feed all the organs of our body. They can cause heart problems. They can cause narrowing of the blood vessels, which can lead to heart disease. They can cause narrowing of blood vessels in the kidneys, which can lead to kidney failure. End up patients on dialysis. It also can cause diabetic ulcers, basically wounds that won't heal because there's not enough blood flow going through those vessels to give them the healing powers. They cause retinopathies, so vision problems. So diabetics know or are advised by their physicians that they sometimes have to see podiatry if they have wounds on their feet. They have to see an ophthalmologist, an eye doctor, to make sure that their vision is staying intact. But it's also, everything comes around to preventative screenings as well as health style modifications. What does that mean? What does it mean, the simple diet? Sometimes it's just a little simple kukish cake, but maybe it's requiring 10 to 15 pounds of weight loss. It's doing simple exercises, walking 20 minutes 3 times a week, which can drastically improve our overall health. I do want to wrap up. I wanted to include, even though there are no women here, but sure we all know people, women are also required or should be recommended to have preventative screenings, both from their OBGYN when it comes to cervical cancer screenings with their pap smears, breast cancer screenings. Dr. Inzlicht, is there anything from a general provider perspective that's different than what we've spoken about tonight that's more applicable just to the women?
Not specifically. Again, genetics is a major factor, and we're all Haimashayidin here, and genetics is, we're a closed society. A lot of us, if you go back 2, 3, 4 generations, we have mixed Baruch Hashem with a lot of the other societies. So the genes very often are carried through. And if there's a problem, we do see problems in families. So it's the same situation. If there's any family history of a close member, and then we should be very, very aggressive. We do recommend mammograms. Now, I know that was very controversial at one point. They came out with a study in Canada that mammograms had too much radiation. With the advent of the new equipment, the digital equipment, the radiation is minimal. You probably get more radiation walking outside with all the antennas, with all the cell phones, than you do from a mammogram every year. And I can just tell you from my own experience, I've been in practice a long time, how many were picked up, how many early, it's almost like we're talking about polyps, how many early tumors or early changes that either are followed or treated are picked up. And I have to say again, Baruch Hashem, the survival rate of breast cancer today by women is so much higher than it was only a generation ago. A generation ago, I don't have to tell you, anybody who's older will remember how many times, how many shiva calls you made for that. And it's not so frequent anymore. Why? Detection. Early detection is the key. And so, a woman has to be trained. Now, one of the problems I'm seeing is sometimes a woman will come in and tell me, did you do a mammogram? No, my gynecologist retired and that belongs to him. It doesn't belong to anyone. You have a PCP, he'll give you the referral, he'll follow up on it. It's not something, we may not do cervical cancer screening, but mammograms should be done by PCPs or by any physician who takes an interest. It's not something that if I didn't go to a gynecologist, I'm not going to do a mammogram. No, you do it regularly. And again, I said it before and I'll say it again, if there's no family history, you still have to do it at a certain point. We recommend from age 40 to do a baseline, and then of course from either, it's still controversial, 45 or 50 to do them yearly. But it should be done on a regular basis because sometimes you pick up something early that you can track. It doesn't mean, and if it does grow or if it's suspicious, you take it out.
I'm going to try to wrap up. I see that they're setting up some booths. I guess that's for the follow-up appointments and any other further information. I think I speak for everyone here on the dais as well as who spoke earlier. We thank you for taking the interest in your own health, your family's health, and everybody else's by attending tonight. But the next step is on you as well. If you're a smoker, no one has to tell you and ask you to please stop smoking. If you haven't seen a primary care physician or a healthcare provider, and you're of any risk factors, any family history, or you're at that age, please make an appointment, see someone, ask for the referral. If it's just for colonoscopy screening, Makdim has a great program that basically delivers everything to your front door except for you showing up to the ambulatory surgery center. Lifestyle changes, as we said, weight loss. I don't have enough time in the world to go into obesity and Ozempic, but if you're going to be started on one, it should be by the advice of a licensed healthcare professional who's following it and doing it with the recommended guidelines. I just want to end off again by thanking the esteemed colleagues up here as well as the previous speakers. Tonight is an amazing event. It has been truly an honor for me to be a part of Makdim's referrals in the community health and the preventative screenings. I'd much rather see you here than in any of my work facilities. And I think the physicians here would rather see you at times of health and preventative screenings than chas v'shalom in times of sakana. So again, thank you and have a good night.
Thank you, Dr. Zimmerman. Also wie hat gesagt, der Eibischte hat geholfen, als man gemacht hat, Keile du, der es will, kann sich ein zu einer von den 4 primary care physicians and simply machen an appointment, push it to get a simple test, a simple blood test. Es ist eine wichtige Sache, es ist eine Schaßakäusche, der Eulim ist eine Säure geworden, sind du available. Noch einmal Yashikachachem, verkimmen und sich mit Status sein.